This conference will now be recorded.
So this one for you.
Okay.
Yeah, you can start when you're ready.
Okay. I will start to take. Okay, I will start to take from her some brief history. How they confirm for her the diagnosis. It's high drops or immune or non-immune. What's her concern? Where they diagnose her? If she has previous baby with the same condition, and just yes, if she has the same condition before. What about her previous obstetric history? How's her another children? If anyone affected or no. Then I will ask about her medical history and surgical previous gynae history also. Um, about this pregnancy, if she did maternal serum screening, she did the anatomy scan, she did all the investigation. I will examine her, will check her the confirmatory test. Then I will ask her what is her concern, why is she refusing to give this baby blood transfusion. Um, okay, then I supposed to explain to her this is like high drops. If we will give the baby blood transfusion, it means this baby he will take the benefit. Otherwise, he will die. Okay, and if she's still refusing, I will let her after
Explain the reason.
explain everything for her and take her concern why she's refusing. I will let her to sign uh, uh, with all the risk for her baby. For her baby, maybe he will die. Then I will give her time also. I will give her like patient information leaflet. I will give her time to think and will give her reappointment after 1 week. Maybe she will change her mind. Or if she
Sure.
wants, I can send her for another fetal maternal.
Yeah, second opinion you can arrange for counseling like that. So as long as the baby is still inside mother's womb, the fetus, then mother is your primary patient, and whatever she will tell you,
She has a right.
you comply with her. Okay, she will sign, and they say that, and the law says that once you have given her adequate information, which is covering all aspects of the care, you have informed her about the risks, and still she is planning to do whatever she has in her mind, then let her sign. At the most, you can give her, like you said, that we can give her another appointment to discuss the issues like that. Okay, so she has signed for it, so it is up to her. And just for the general knowledge, like 3% of the children which are affected, half of, this is the incidence. If 100 babies, they will have high drops. 3% is the death rate in them. So 3% will develop severe clinical anemia, and 1.5% they will die. So this is in addition to the background risk. Background risk is 5 in 1 in 200, and then this one, zero point 0.5, and then the risk would increase to 2% like that, which is like very high. and because of a cause which can be prevented. Okay, Dr. Muhannad, please, this one for you.
طيب اوكي بسم الله. Parent women with previous section have been advised to go to delivery while in labor. She wants to have a section because she's worried about rupture of vaginal testicular connection. Recommending that the labor would progress without complication. Should this طيب first I will take choose myself, Dr. Mohamed Hawari. What's your name? What's your age? Social issue يعني smoker or non-smoker. I will ask her now she's in labor. I will ask her previous history. I will ask her how is the pregnancy happening, the interval between undesired or non-desired, interval, any complication in current pregnancy, any pregnancy come from the dating, and hemoglobin and placenta locations, and she's bleeding or not, and since we see eruption brain, and I will ask her about it has abdominal pain or not, still abdominal pain or not, contracted, vital presentation, and vital growth, and Doppler and CTG. CTG is fine. I ask about for her previous cesarean sections. At what time, at what age they did cesarean section? At what type of scar had been done for her? Was it emergency or emergency or elective? And any complication happened post surgical? And they advise her to go for vaginal delivery on which was she counseled about vaginal delivery for the section before. This is the first counseling. And does she know the complication of does she know the risk of going for vaginal delivery versus going for the section? And I will check for her surgical history, medical history, diabetic hypertension and medication, surgical history of DLC or not, and how many surgeries she had before, and a smoker, and gyne history, LMB cycle regular, pap smear, CDs, GPS testing, and HPV, hepatitis B and C, and VID, and social history. If a smoker, alcoholic, smoker, alcoholic, drug intake. What's his medication on it right now? She's aspirin, insulin, and enoxaparin, and when the last time she's taken antistrogenic medication. Any other issues? Any blood transfusion before? Any allergic medication? Any blood transfusion before? And then I will ask about what she knows about why she went for the section. What's her risk? Does she know the risk of the section going for delivery? I will tell her that it's depending on her. I will tell her I will tell her the risk benefit. The benefit of vaginal delivery is that success rate is that from 50 to 80%, and it depends if she had if you have vaginal delivery before or not, at what time we have her age, her obesity as well could reduce the risk, could increase the risk of vaginal section, and the interval between pregnancy and delivery could increase the risk of could increase the risk. The benefit of vaginal delivery is that less pain, less hospital admission, and quick recovery, and she can go for and less risk of postpartum hemorrhage, and risk of adhesion, and then she can, and if she's in pain, we can give her, and this is for benefit of vaginal delivery, and more cosmetic, and less risk of infection, and risk of benefit of and the risk of vaginal delivery is that she might need emergency section if she have if indicated, if she has sign of scar rupture, or which is very low, in her case, well, about 1 to 2% if she has lower sigmoid scar. Even if she has previous 2, it is up to 3%. And I will give her and the benefit and risk of the section is that it is a quick okay, it is quick delivery, but it's quick delivery for her. But there is risk of infection, risk of bleeding, risk of hysterectomy, risk of adhesion, risk of risk of لا إله إلا الله risk of hysterectomy, risk of risk of BBH, and risk of putting backbone insertion more, and risk of increased risk of the rupture in her next pregnancy if she opted for vaginal delivery. And this is the benefit and risk. I will ask what's his concern regarding what she's afraid of exactly. She's afraid of rupture uterus, or she doesn't want or the pain is the one who's concerned her. Then I will tell her that it's her choice to choose, and if she want to choose, as I explained, the risk and benefit from for which one. And so I will simply follow the ICE guidelines, the ICE mnemonic, idea, idea, and
Concerns and expectations.
certain as expectation. So idea, what the idea, what is idea, what is her certainty, what you want, and her expectation, what's happening with the pregnancy. Then after that, after I give her option, it's her option to do this once. But before we check her, before we take for the section, I will tell her I need to check her investigation before that to be ready. I will, if she chooses for the section, I'll tell her choice. I will check her investigation to be ready, the CBC, urine platelet, urine isolation culture, and LFT and RFT, and and ECG if it's more than 40 or 50, and HB screening, and her her CTG and her ultrasound finding to prepare before we're going to R. If she's going for vaginal delivery, I will check her. I'll check all the finding. I will check. I will check all the finding more than to be sure that she's no short interval pregnancy, which is less than 18 months according to COG guidelines. She can go for delivery even if it's less than that, but there's increased risk of rupture uterus, which the patient will be informed about it. I will check her fetal lie. I will check her placental location, just to rule out any contraindication for vaginal delivery.
Yeah. So once you have a patient like this, you have given her all information, okay? But still, she is scared that no, she's going to meet some untoward incident. So what will be your last action? So you will go for the section or you will not?
I will ask. I will try to call my consultant first to talk to the patient as second opinion. If the patient still want to go for the section, I will give her this her right. We'll take it for all.
Yes, because in the end, your patient is not comfortable. Give her all the information you can give so that she will be comfortable. And usually, when you will consult the patient nicely, they will agree. Reassurance is what is required. And when they made the decision about this normal going for the normal delivery, they explained everything to her. So again, you will confirm that things were explained to you. I will try to explain again, and if you have any question, tell me. Tell me why you are scared of having this ruptured uterus. The chance of it is point in points 0.02 to 0.09% like that. Okay, so it's very low, and we are here to help you. We are observing you very closely, and we will see if any time any problem will occur. We are all here to care for you like that. Okay, you have to reassure the patient. And still, after reasonable reasoning and reassurance, still she is like that, then you will have to document and take her to the OR. because she is willing to because the surgery, even the surgery is not without hazards. So we have explained everything. What are the chances of success of TOLAC, like up to 85%. So, and if she's what are the chances of having repeat sections, placenta accreta, placenta previa? They are genuine material risks in which patient will suffer a lot. Still, if you will head for that, then you have to do that. There can be a reverse situation, like when the section is necessary, there is severe fetal distress, but the mother has declined any intervention. So again, you will be doing the same things. Explain everything to her, and in the end, she is not agreeing, document everything, and then you will go for it. Such situations are common, but you have to diffuse the situations. Commonly, it happens like this is just an observation, not supported by data or evidence, that usually the patients who are like anticipating the problems and something happens, then they are the one who go and they complain you like. Okay? So just counsel her. Maybe she has tocophobia. What is tocophobia? The fear of having childbirth. So explain to her, see that what information she has, what is guiding her thought process, why she is focused on this thing that she is going to have this uterine rupture of the scar. And after explaining, still she is adamant, then you will document all the documentation, inform the senior, and take the patient to the OBGYN. Okay, thank you. Dr. Fatma.
Hi, doctor. How are you?
I'm good. How are you?
Alhamdulillah. Okay. So, they came to me for fertility issues and for ovulation induction, and I had to consult them and split the patient has primary amenorrhea. She hadn't cycled before. Anyhow,
Yes.
first of all, um, I will take a proper history from the patient, and I assume that the patient here alone with me in the clinic. So I will ask her if she had any menstruation before, and if she doesn't, what are the investigation that she went through, and if there is a diagnosis for her regarding her primary amenorrhea, and she wants to reveal it for me right now. If she didn't do anything, I will go for investigation. I will do karyotyping. I will do image. First of all, I will do imaging, either by ultrasound or MRI. I will do hormonal study, TSH, FSH, prolactin, anti-Mullerian hormone, testosterone, dihydrotestosterone sulfate, 17-hydroxyprogesterone, and I will do like physical examination for her if there is any stigmata of Turner or androgen insensitivity, or she has Mayer-Rukhtinansky-Kasser-Hasser syndrome by like I didn't see uterus by ultrasound. I will rule out everything and I will check if there is anything the previously mentioned she has, or she has like FMR gene mutation, pre-mutation sequence. And regarding that, I will tell her that it is that I cannot do for you like ovulation induction if you do not have like a ovary to be stimulated, and your karyotype, for example, male, but you are phenotypically female. So according to her diagnosis, if she has like if she is, for example, she has ovarian dysgenesis, I will counsel her to have adoption or like to be surrogate mother, or in case of she is androgen insensity or Myrick-Kurtinesky, also adoption. So I will counsel her that we cannot do anything for this, and we cannot give your husband false hope, and we cannot tell him like false information or false information about you. So you have to tell him the truth, and yes, she has to tell him the truth. But for me, I cannot tell him like the truth and go for her wishes. But I have to document everything in the file in a truthful way, and that's it.
Yes, that's all you need to do her. And you will like, she's telling you that she is, and she doesn't want to spoil her relationship like that, so she needs counseling. That what she is losing, what will happen? Always ask your patient what will happen if the other person will know about that. Because you will encourage the patient to tell her husband, and because there are multiple aspects. Like we are wasting important resources. We are, most importantly, we are just spending time. That is one thing. Okay. And the such treatments like the ART, they are quite expensive. And then there is some element of deception like that. Okay. So you need to encourage her to tell her husband. If she is not, then you will have, you refer them to the counselor who is going to counsel them about the condition, because it is very hard to accept the reality. So the counselor can make this process smoother for them. So you will counsel them, you will interview them separately, you will encourage the patient. If she is not breaking, you will not be the one to break the news, because the patient will sue you that you have breached her confidentiality. So send them to the counselors. Counselors have special protection. They cannot be prosecuted in the court. So they are going to do the joint sessions for the couple, for the therapy, and for disclosing this thing, because they are not getting anywhere. And this is unnecessary exposure to the drugs, which are never going to help her. Rather, they can increase the complications for her. Then, like Dr. Fatma said, she needs full evaluation that what is the cause of this primary amenorrhea. Is it treatable or is not treatable, like that? Okay, and that is the way forward. Okay, thank you. Dr. Rukaiya.
Okay. Stop. Okay, I will ask this patient. I'll introduce myself to her, greeting her. I will confirm her a name and her age, then her gravida, baral, ethnicity, consanguinity, and her occupation. I will ask her how she is diagnosed, who diagnosed her, before how many years, and what is the source of her the transmission of HIV. Also, will ask her about her a symptom, if she has any symptom right now, and we'll ask her about her pregnancy. She did her LMB, if regular or irregular cycle, her ultrasound, if she did the NT scan or no, and the blood serology also for her. If she did the hepatitis B also and C, syphilis, or not yet done. I will ask her also about relationship with the husband. If she has one partner or more, what about her husband? If he's HIV positive or negative, and if this pregnancy is spontaneous or IVF with the ICSI. And we'll ask her about her medical history, if she's diabetic, hypertension, her surgery history also, if she did any operation before, her gynae history, if she's using contraceptive, she has to confirm another sexual transmitted disease, she has PID, if she's using any medication, she started already in the heart disease or no, for the HIV. What medication right now she's using other than the vitamins and the folic acid. If she's smoking, drinking alcohol, her family history of any other one have the same issue. I will do for her also full examination with confirm the viability of the baby. If an investigation not done, I will do for her the investigation also. And then I will ask her about her طب her husband دكتورة positive or negative?
Yeah. Her husband,
He
she's still not tested for it. This is just,
uh,
she was diagnosed on routine testing and she doesn't know what is the status of the husband.
okay. طب at that time I need to do for her the full investigation. I will counsel her. She's supposed to be her husband يعني at least because you need to do the test for her husband because this sexual transmitted disease, and better to treat her and her husband also early. Um, okay, and I will refer her to infectious disease, and we will refer them also for there is HIV center also. I forget, and even we need to inform like the center, like government for the HIV people. And I can, if she's still refusing, we will refer her also for the like for the social or
Mm-hmm.
infection. I will give her time.
Mm-hmm.
I will make for her. I will give her the information leaflet about the HIV, and I will inform her to read. Then she will come, and I will counsel her to think about that because we're supposed to inform her husband. At least they will take care, and we will reduce if for the next pregnancy also to
Mm-hmm.
reduce the risk for the baby also.
Okay. So she's telling that don't share this information with anyone. So we need to ask her that what is she losing, what is she afraid of, and then we need to counsel her in a good way that it is very important to disclose this information to her husband, and because he is at risk of getting this infection and we don't know his status like that. Okay, and so he also needs evaluation. For this patient, you will ask her about history of any blood transfusions. Did she ever met any accident, any history of using drugs? And then you need to do, remember the basics that if one STI is positive, you should go and test the other STIs as well. So she is a primary gravid, right? So screen her for Hepa B and screen her for
Yes.
Hepa C, and ask her about the recreational drugs. Did she ever injected drugs? Okay. Did she ever receive blood transfusion? Why? Because this HIV sexual route is just one of the routes. Okay. Maybe she was using the needles. They were sharing needles. So many things are they could have happened like that. Okay? Maybe she received blood transfusion. All of these are modes of transmission. So counsel her that it is important to disclose her to not those who are caring for her. Her healthcare team should know about her because all of them are at risk. Okay, it is important, but outside this healthcare team nobody would know, and the husband is also directly at risk of acquiring this infection. He has the right to know about it. So evaluate the patient, screen her for the other disorders, inform and ask, encourage her to break the, this bad news for her husband. If she doesn't, then you will have to do that yourself through the counselor. Similarly, sometimes they can, yeah, and this is important for her because the viral loads, they should be determined. Her treatment should be initiated. Her pregnancy should be monitored in a different way. She should be seen every 1 to 2 weeks. We need to do the growth scans. We need to make a plan around the time of delivery. We need to give her the medications to suppress the viruses and to protect her if she needs any additional therapies. That is one thing. Okay, so very important for her. And then we have to plan the mode of delivery. So all of these things, they cannot be like hidden from the healthcare team. So it is important. And the husband, maybe he also needs the treatment, so we need to break the confidentiality. Sometimes they will tell you that the doctor is treating the patients and the doctor has HIV and he is already suicidal and he doesn't want anyone to know about his condition like that. So there also you have to counsel him reasonably, and you have to give him the information. You have to give him all the help to support himself so that he will go and he will get the treatments like that. Okay, so that's important, and document everything. So when the other party is at risk, the people who are treating her, they are also at risk, so you will have to break the confidentiality. You will breach the confidentiality at that time. Thank you, Dr. Muhammad.
طيب severity scoliosis you will confirm condition دكتور what the meaning of SIRI ايش هذا؟
Serious incident reporting.
Oh.
Indications like that. SIRI means serious incident, like we are writing the OVR, right? So these are serious incidents reporting.
And RSCA is ما أدري. طيب first I will first I will introduce myself to the patient. I will ask what's your name. If she's standing, I will be standing. If she's sitting, I will be sitting. I will try to talk to the patient. So what's the issue there? And what's the issue there? I will tell her what's happening. I will let her vent what's going on there. I will first I will explain that we are sorry that's happened. We're sorry that happened. It was most likely was unintentional. We will look for the cause. I will tell her that what's happened to her, and we will look for the most likely it is or explain to her condition first. Most likely it is due to her HPV infection. Could be background infection. Even if we have even if treatment with severe sclerosis, there is cases could be progress ovarian cancer within 90% of them. They would have already background ovarian cancer risk already. Not sorry, 90% of the cases they already have ovarian cancer. If we do for them laparoscopy, colposcopy. So this could be this could be the cause of his case, cause of cancer, or she had the cancer already. I will tell that we identify that I will identify why we will look for why this happened, and we look for the causes. We try to analyze the causes why it happened, from where it happened, from where the reporting was done. Could be the report from the lab, from the lab, from the lab. No, excuse me, from the lab was misdiagnosed initially from the lab, and no after that maybe it could be from the doctors, maybe it could be from maybe it could be the initial report didn't show that. The initial report, we'll look for the cause. After that, we will do professional report, in which that report will be The report will be the report will be sent to the department to look for to the department and to the administration to look for to check to prevent this from again. We'll put inshallah algorithm to prevent this happen again, and we will check inshallah after 6 months. And we'll do auditing after we put strategy to prevent from this condition from happening again, and we will go for and we'll do auditing now and 6 months to see is it gonna be effective, and how is our implementation is gonna be or not. I'm sorry that's happened to you. We are trying to, as much as we don't like it to happen to any of our patients, even our relative. We're trying to it should not be happened, and we'll try to minimize to prevent this happening next time. So this was the serious incident report. What about RMRCA? So what is this one exactly? This is for auditing or reporting. Hello?
Yeah, I'm listening. So if you have to classify this event, this is a sentinel event or this is a near miss or what?
I will I will say the sentinel event. It is cervical cancer.
Yes, this is a cancer. Okay, so this is something more serious like that. Okay.
Even if you have
Usually,
background risk of cervical cancer already with severe discourse, there's already background risk of cervical cancer if you go to the if you did laparoscopy, but it should consider as sentinel serious sentinel serious incident.
yeah, this patient can take you anywhere like that. Okay, and this patient will complain, and then of course we need to review our system. Okay, first we have to launch OVR that this thing has happened because we are not the one who has caused it. Okay? And then we will have to make a committee to analyze the risk that what has happened, where the things were missed like that. Okay, and they will do the root cause analysis. Most commonly what happens, the patients they will change their location and they will not update their address, their contact information into their records. So such things would happen. But usually what happens that when they're sending the reports in our system, the patient
Mm.
keeps changing from the government hospital to the private hospitals like that. Okay. So there are policies in place that we have to track the patient that where is the patient now like that. So they can take all the help. But something somewhere has gone wrong. So we have to see that what were the events. We can the patient will say that I want to complain the doctors. You will say that you have the right to do that, but first we need to look into the matter. What has happened? Where was the fault? Where was the defect in the system? Because nothing is
Mm.
acting independently. There is a full chain like that. Okay. So the patient change, it was on part of the patient or it was on part of the team. Why they didn't track the patient? Why they didn't ensure? Whose job was that to ensure? Clinical risk committee that the managers they have to be they are responsible for such things that they imparted they posted all results and then that is the reason that we are asking the patient what is the best way to convey information to you. So this chain was broken somewhere. We need to find out where is this thing. So and then educate the staff about it and for the patient how you will compensate. This patient will ask for money or something, and the hospital or the healthcare will have to do that. That is one thing. Okay. So communication, this is also a very important form of communication. Just by releasing the results or giving the comments, you are not out of it. You have to be sure that the message has reached your patient like that. Okay. So
Mm.
you can also say that the system should be checked and where is the defect, it should be fixed like that. Okay. This patient will ask you that I want to complain and you will counsel her that she can go to patient liaison committee who are going to register her complaint and do the needful and we are going to do the internal investigation as well as some such matters they can be investigated externally as well. That some other hospitals head can come head of this quality control can come and see your system that why things are happening here like that. Okay, well done. Okay,
Uh,
Fatma.
doctor, I had a question on the previous case.
Yeah,
Uh, you mentioned that it is a sentinel event. Shall we consider it
near
sentinel? It
near
should be
near
near
miss,
miss. Yes,
near
okay,
miss.
okay.
Sentinel events are the things which have
Yeah.
happened, we have seen, but which are very likely to occur like that. Okay. This is a near miss because this is something very, very serious. And once it will happen, people will be alert. They will be more careful. So that is a near miss. The sentinel events are like, if you
Usually
ask,
act lead
Mhm.
to this sentinel.
Sorry,
Sentinel, the event that lead to death.
that
Sentinel.
sentinel will not lead to death. Sentinel would be something which is bad, it has happened, and it is very likely to happen again by definition. Okay, that is the definition of the sentinel. Like the sentinel events, like I will give you examples, then it will be more clear. In
Mm.
the surgical world, in which we include the gynae, there are two most common sentinel events. First one is wrong site surgery. The second one is retained surgical foreign bodies. These two are the most common. So these two things, they are likely to happen again because somebody somewhere will forget like that. Okay. So like the patient has fallen down inside hospital, that is also sentinel event. That is one thing. Okay. Here, I will agree in a couple of things with you. If we can classify actually it as sentinel also because there is delay in the treatment. Delay in the treatment is also sentinel. And then the near miss, that if it had been missed, it would have caused death of the patient. So it is not like mutually exclusive. Okay, two things, sentinel and near miss can be there like that. There are borderline, the cases, so can be like that because there is, you can diagnose that there is a delay in the treatment, but near miss because even if at this point you are not treating, it would lead to death of the patient, would have led to the death of the patient. So delay in the treatment and the serious harm. These are two things, and two things can coexist. You don't have to worry about it. That is one
Doctor, a
thing.
delay of the treatment is not negligence.
Delay in the treatment is negligence. Clinical negligence is also there. What I'm trying to point out here is that it is not necessary that this is a serious incident, then it cannot be risk management issue like that. Things may coexist. Negligence can be there, but there are types of negligence. How much material harm your patient has got like that. Okay. Suicide, patient suicide, that is also sentinel. A patient have or the doctor has committed suicide. It could have been prevented, but it is successful now. Attempted suicide like that. Okay. Assault, rape, sexual assault of a patient, sexual assault of the healthcare provider. Then the patient has, sometimes the patients are drinking this bleach, Clorox inside hospital. That is also a sentinel event. Such things should not be in reach of the patient. Patient has jumped out of the window like that. That is also a sentinel event, which is causing serious harm. But this is something which is likely to occur again as well. So unless we change the things, then fire. Then the patient was supposed to take antibiotic, but the nurse by mistake has given her insulin. So that is also considered a sentinel event. While it can
It's not
cause death,
medical. But what about the medical error?
medical errors, different types. I'm telling you, medication errors are also included in the
Sentinel.
sentinel events.
But if something happened for the patient,
Something happened for the patient, still it is a serious thing, but it is grouped in the sentinel events, medication errors. Because anything which is bad and which is very likely to occur again, that is a sentinel event like that. Okay, you have got it now, but it will occur again unless we change our system and we improve the checks. Medication management, that is also sentinel event. Then clinical alarm response, like it was not registered. Like if something serious is going on and we are telling the doctors, the patients, the safety alarms are ringing, but they are not responding to that. Something happened. So that is also a sentinel event. Like I told you that the most relevant for you people are like two, wrong side surgery, okay, and then which is likely to occur again like that.
or misgoes. طيب
And then the near
دكتورة,
miss.
if we have
Mm-hmm. Yeah.
if we
Or
have the same like one patient,
mm-hmm.
the doctor he informed her result is normal.
Mm-hmm.
Okay, like
Yeah.
pap smear is normal and it's abnormal. After that she progress something يعني advanced. At that time, if patient she don't have ID at all, يعني the doctor he did some mistake.
Mm.
يعني from our and what we supposed to do?
No, you have to report that. You have
طب
to
we will
report to. Yeah.
we will report. Okay, we will report. But after that, the patient she don't have any idea. There's يعني like negligence from the doctor because that she reached till this. I will يعني encourage her to go and complain.
Yes. This
It should
is.
be
If I
by the
ask you, near misses are more serious or the sentinel event, what will be your answer?
Symptom.
what was the question?
Because in near misses, that is some accident which could have resulted in harm, but it has not, but it has been captured somewhere like that. Like in the, it was in the surrounding of the patient, or the patient has harmed herself, patient has suffered from that thing like that. Okay. So it can, if for me, the sentinel events, they will be like more serious, and the delay in treatment is one of them. So here, what do you think? You will apply in this one, the treatment has been delayed or still we are safe for this patient?
No, it's something يعني there is يعني I know there is mistake from the doctor, but like
Yes.
we will make the يعني incident report, and then I supposed to inform the patient, go and complain against that one.
Come on, not in this way أحس يعني.
Yeah, OPR is not against anyone. It is something
Yeah,
which is
I mean, if patient she don't have idea, now I will review. مثلا she's follow up in the same hospital. I will review. I will see really she has abnormal result since long time, but I will see the document of the primary doctor. He said everything normal, and he don't refer the patient to the colposcopy for anything. Then she came later with the advance. يعني now the ethics. I cannot tell the patient go and complain against this one.
yeah, that will be like a very bad thing to do. That we should not be doing that because, but you will now, you remember, serious incident reporting, it is not against somebody, it is to improve the function. Here, your patient, I will classify that one as the sentinel event. You know, these three definitions are so confusing that this is a tool. Writing the OVR, that is a tool. Okay. Near miss is not a near miss or sentinel event. These are events. These are the facts. Okay. These are not tools. I will tell you. OVR is a tool when in which you are telling the department that something has gone wrong, and if you have looked at the OVR paper, it has got like several parts. Who is at harm? Who is at potential harm? And where you think is the fault? Okay, so you are just giving your opinion. Okay, what happened? You are just giving in the OVR, you are just going according to the timeline. What happened? Who came here? What was the incident? And why we are talking about it like that? Okay, that is one thing. Then we are leaving one part empty where the people who are reviewing that OVR, they will sit together. What they will do, if everyone who came across that patient when caring for her, they are going to write down their perspective, okay, and then in the light of that one, we are responsible for giving a suitable reply to the patient, which should be based on the facts like that. Okay, so that is one of the things. So delay in the treatment, Fatma asked, that was a good question. I think that is a sentinel event by definition. Okay, when it was dyskaryosis, at that point it would have been a near miss like that, that there is a possibility that we ignore that patient like that. But in the dyskaryosis, the patient has not suffered the harm. But when your patient has suffered harm, like in this case, like now she has returned with a full cancer, so that is a sentinel event. It's very, very important to have the accurate definitions, because sometimes they will ask you that what is this thing, what exactly your patient had like that. Okay, so and most of the events where they will draw your attention, that will be a sentinel event like that. So if and I told you like the foreign bodies, if they will ask you, it will be about forgotten foreign body like that. So just it should be on your fingertips. Okay, that is a sentinel event. Most of the events they will bring for you in the exam, they will be sentinel events like that. So we just went over the most common sentinel events. Will you like to tell me again that what are the most common sentinel events? Like retained foreign body, okay, like the we have forgotten the gauze inside body of the patient, okay, and then we have done wrong site surgery, okay, that is one thing. Then can be delay in treatment. The patient has fallen down inside hospital. It happens. Those who are hypoglycemics, they can fall. Then patient was at risk of suicide and nothing was done for her. That is also sentinel event. Then the patient has harmed herself. She has cut her. Have you ever thought that why do they give these plastic knives and the stuff inside hospital? And other thing, they don't put these latches. When we are going to the bathroom, we are closing the latch. So the latches are not there. Okay, the patient cannot lock the door like that. Okay, they will just go inside, and the other members in the room, they know that the patient is inside, so nobody would go inside. Why? Because we are trying to decrease the risk like that. Okay. So these are the things. Medication management, medication error, clinical alarm response was buzzed, but nobody responded to that. All of these are fire was inside hospital. Okay, the patient has suffered from the inhalational injuries inside hospital or in her home. So all of these are like the sentinel events.
What about Dr. Rupture uterus inside the hospital and IUFD?
Ruptured uterus
The
and
same?
IUFD, this is like the serious incident.
No, I mean
Something like
IUFD inside the hospital. يعني she came with the baby alive, then IUFD inside the hospital.
Yeah, this is serious incident because anything it has resulted in the material harm, that is like a very serious incident.
Okay.
I have a question. It might be not related, but now it came in my
No
mind.
problem. Welcome. Yeah.
What if what if there was a fire at hospital and I was
Mhm.
inside OR doing CS to the patient? What shall I do?
You will complete the procedure like that. Okay. If the fire is directly inside hospital, obviously what happens, have you ever noticed that the roofs of the hospital, they have got the sensors? In case of fire, what happens, the water, when there are smoke detectors, okay, so they will start raining. Even in the hotel rooms and in the ORs, these fountains are everywhere. So slight smoke is detected and then this water will start pouring. You are going to expedite the procedure. You are going to complete your surgery, okay? And then you can leave.
Or you can burn with the with the patient.
I will tell you something. In all other things, the point is, if you have attended these also drills, what they do is that they will take the sheet and everything, and then they will jump or they will just slide. But this cannot be done in case of the OR patient like that. Okay?
Yeah.
So that's why in the whole hospital, if you will go, ORs are the best equipped things,
Mm.
to deal with all sorts of emergencies, and always the staff is adequate like that. And they're not made in the middle of the hospital. They are on one side of the hospital, and if you will notice, they have like their own separate ladders and they go down from there like that. Okay, and usually And the recommendation is like you have a point here that they will not make they will not make these stairs. There are like slopes. We call them slopes, okay? But the problem is that all of the equipment and the things, the time you will take to take the patient out, by that time you would have completed the surgery, okay? And after that you can take like you can go down the slide like that. It's a very, very remote possibility, but still it occurs. Like you will expedite, you will complete the procedure and leave with that, or at least stop the bleeding, because you know your patient is on the gases. Patient can't breathe. Patient is under anesthesia. And if you have looked at the anesthesia machine and the things, now they have got modern ones, but still to take the sophisticated equipment downwards and doing everything is going to be like very challenging. So the hospital, the OR is one of the safest places in the hospital, even safer than the ICU. Let me tell you this thing.
Mhm.
What do you think? Why they don't allow anyone to smoke inside OR?
Yeah, because of
Fire
the.
extinguishers, right?
Mm,
Fire extinguishers, plenty of them. You will see in each room, each corridor, multiple. Okay. And
mm,
the staff, they are trained that how they are going to set the fire, put the fire off like that. So everyone should be, that's why they do the fire drills, okay? Your patients are in the DR, you will take the patient with the, they once they brought a question like this, and the answer for that was that the patient was in the on the laboring unit like that, okay, labor ward. So what they did was that just pull the patient down with with a sheet and everything, and then roll out of the room like that. That is one thing. Patient is choking, hold her from the back and go out like that. These are the things. But skill drills, safe buildings, exits are very important. So if you will go to your hospital, now look at this at like this. DR, it will also have always have its stairs towards the exterior of the hospital. OR, they will have the same thing. So exits, why do they make so many exits and they display them very prominently? They're not telling us that we have to leave the space like this. This is to facilitate the staff. So when we talk about the environment, when we start resuscitation, the first thing is environment, where you are, how you will run, how you will keep your patient safe like that. Okay, these are the things. Actually, once what happened, and the fire. And tell me one thing, where do the fires usually start? There is
This
your.
yeah.
conference will now be recorded.
Oh, sorry. Where is that? Here it is. Yeah.
Okay.
Okay, dear.
So you think this patient need to be repaired in the theater, and you asked help of your colleague. What you will tell him? I will tell him that my patient have extended cervical tear, and I will conduct for him the amount of bleeding currently, and I should transfer her to the theater as I cannot do this kind of cervical tears in delivery room without proper analgesia, without proper mode of anesthesia. That's what I will tell him. Uh, Examiner gave a scenario that your colleague is busy and asked you to repair
In
her
delivery room.
room instead of OR. What is your action? I will refuse that. and I will call my consultant, and I will tell him that this patient should be transferred to OR to have good anesthesia and good analgesia and good exposure, as this is impossible to be done here in the delivery room. And I will take her to then after I call anesthesia and I arrange blood, I will transfer her to operation room.
Yeah.
After you took her to OR and finished your repair, what is your next step? My next step, I will document whatever happened uh, since patient delivery, and the finding that we found, and whatever happened between me and my colleague, and I will document that he refused, and delaying of time was because of him, yes, like I will document it, then I will write incident report, and I will report it to the medical management in the hospital, and yeah, and I will you sit with the patient and her husband, angry considered what happened is medical error. What are you going to do? Okay, I will assure him that I will that incident report already raised, and we have done like risk management team, and we discussed the root cause analysis, and like root cause analysis, whether the patient had extended cervical tear, and the hospital factor, and the physician factor, which was like delaying and taking decision, and poor communication, and after that I will assure him that this this will not recur again. This occurrence will not recur again, and I will assure him that the incident report raised to the hospital management, and to the Ministry of Health also, and we will be sure to make a good audit for whatever happened, and and uh, um, I will give him summary for whatever happened, and
What action
yeah,
was taken? Yeah. And you will
yeah,
try to find the solution
yes.
like that. Okay.
Mm. So why we need to disclose medical error, if any, to help for improvement of health service, and
Mm-hmm.
that and this is the patient right to know whatever happened regarding her health, and it's her right if she wants to sue the one that was responsible, and to improve health service, and to be sure that it will not recur again,
Yeah.
to improve quality of health services.
Yes.
Yeah,
Excellent.
I can the picture now. Disappeared.
Well, yeah. One very easy tip, well done. One very easy tip to get high scores on the OSCE would be try to finish your station on a positive note. Okay. because give them solutions. If you are telling them the solution and you are ending it on a body note, a positive note, they are going to give you good marks on that. Okay, because everybody wants solution. Why people are fighting? Because they don't have the solutions. Okay, that is the problem. They cannot find their way around some difficult issue, so that's how they are showing their anger, their frustration. So maybe they are asking you indirectly to help you like that. So now just we talked about like the retained surgical bodies, or that is one thing. These can be like these things, they can occur at the time of surgery, or they can occur when you're dealing with the patient, like we are forgetting the gauzes, something, and then sometimes during surgeries the things are left inside the body like that. Okay. So we bracket them into the sentinel events like that. So if they give you anyone with a retained foreign body and they have come to you and they are complaining about it, so they can come back to you with the specific complaints, with the non-specific complaints. You should keep in mind everyone is not symptomatic like that. Okay, they can be septic, they can be aseptic, and generally if they ask you what can happen if a foreign body is retained, there can be inflammation, there can be formation of a mass around it, there can be fistula formation, sinus. If they are inside the tummy, they can cause blockage. They can cause blockage, obstruction. Okay, they can cause severe peritonitis, severe pain, acute pain, and then you will have to do the surgery like that. Okay. So sometimes if these surgical bodies are retained, usually you will have to go for the second surgery to remove them. So this can be very serious like that. Okay. So mostly they will ask you about the things that what could have happened, how we can treat them, and what how we can prevent such things like that. Okay. If this has occurred at the time of surgery, you should know that how you can prevent it. Extensive training, the system should be there for the checking the things, you know that full staff should be there. If there is shortage of staff, always ask for the more staff. Okay, lack of staff or the surgeon was overworked, these are no excuses like that. I mean, I know that these are the excuses, these are facts actually that the things would happen, but the problem is that nobody registers them. They will ask you, so if there was shortage of a nurse, so did you request the nursing office to give you another one? So if you never made a request in the first place, then it will be on us, our fault. Okay, so we have to protect ourselves as well. So document everything and don't compromise on less optimal conditions, because they are going to cause harm to you and harm to the patient, harm to the organization at all levels like that. Okay, so for prevention, adequate staffing should be there, adequate training should be there, and you know, if you need help, like the staff is not full, it is lacking, you need to call that. Drugs are not available, always notify the nursing office that we don't have the drugs. Always notify the administrator on duty, the managers. Okay, that's why they are sitting over there. You needed one surgeon to come and help you, he didn't come, inform the manager like that. He's the one who is going to bring them to the hospital like that. So training is important. When you people are undergoing training, it is not only the relevant to the field of the medicine that you are training yourself. You are why we are focusing on the communication, because you should be able to raise your concerns. Your voice should be heard. Actions should be taken like that. Okay, and then you are able to calculate that how much risk is there in the environment. If you will continue working like this, you are going to get harmed by the system, by something is lacking, so everything will be on your head by the end of the day like that. Okay, so training, even for prevention of these retained surgical bodies, training, the scrub nurse. Okay, time in, okay, time out, everything, check in when you are starting, everything should be mentioned. So the roaming nurse, she is responsible for writing down everything. She is the one who is going to ask everyone that what is who they are, identify yourself, what is your job, what is your role in this patient's care, why you are here, and what are you intending to do. Do you anticipate any non-routine steps? Do you think that this patient would need a blood transfusion? And then once you are closing the abdomen, always do certain things before closing the peritoneum, before closing the rectus sheath. Ask the nurses, counts are complete, needles are there, and look at all the pedicles that there is no bleeding, nothing, abdominal cavity is clean, and ask your assistant to look second time. Okay, then again ask the sister second time. So can we proceed to close this practice? So always do that. Never leave your needle without needle holder. Always hold that in place like that. Okay, nowadays they have got the portable x-rays so they can spot the things. If the needle something is missing at that time, just tell them to bring the portable x-ray. They will come, they will do everything, and you can take the thing out. Here the point is that most of the needles are radio opaque, like they will appear as white objects on the x-ray, so they are opaque. Okay, opaque, open, they are visible. So we can remove those things now. In the past, it used to be very hard, like they had to bring the large X-ray machines and they used magnets to hold to attract the needles like that. But luckily now the things are far easier. Okay, you can make use of the ultrasound if you're not finding something like that. Okay, so be careful. There are resources to help you, so use them when needed. Counts and then the time points. What time we did what, things are fine, everything is okay, so this is the time and we are going to close it now like that. Okay, inform everyone that take care of your things. So they should count their pads also, packs also as well, very important thing. Small, and never use small gauzes. Okay, always if they say that doctor today we are short of it, then you should tell them no, I insist, I need a large pack, give me that. If they're not giving you the large bag, then tell them that take like 5 gauzes and wrap them in one gauze like that. Okay, so make it like a ball and then I will clean the patient. And for such cases, don't go loosely. I know that you people will not go like this. You will always hold that in the sponge holding forceps and clean the area like that. Okay, look out of these things, and then I mean you are ensuring that nothing is, you have not left anything inside. Similarly, when you are going to the DR, you are doing episiotomy, anything, again, you are the one responsible, because if you are on call, you are responsible. So ask for assistance. Take the trained staff. Tell them clearly, don't use small gauze pieces. They are always bad news. You know, the gauze pieces that like the cherry things, they are always a bad news. Cherries and the peanuts. Use them in the whole sponge holding forceps like that. Okay? Don't use them separately like that. Go for the large packs. Even if when you have to pack the vagina, take the gauze, take the pack with the hand, with a strip, you know, from where you can hold it like that. Okay, so the string should be there and you should be able to remove that. That is the point. So a trained person should be there. Always do everything under good light so that you can inspect. And here also, don't think that then this woman has delivered vaginally. Ask them for the counts. Actually, they are doing, but if they forget, it should be your second nature. Wherever you go, involve people, take their attention so that they will do their things nicely. What happens that the woman has delivered, everybody is relaxed, happy that the baby has been delivered, so congratulate, and then call sister, call my husband, tell him to bring this thing. I have seen these things so many times, and I used to react to these things that no, don't call anyone. If she has to call, let her call. This is not your job. Look, pay attention that we are not forgetting anything inside body of the patient like that. Okay, because it will have serious consequences. You are doing episiotomy, again, good light, large bag, and see the things clearly. Again, ask them your needles are complete. Like usually there should be 2 needles. Okay, happy with that thing. Your RT forceps are there. We are not, obviously you cannot place the RT forceps inside vagina, but ask them. Everything is there. Counts are there. Threads are there like that. Okay, and especially the gauze pieces, they are there like that. Okay, clean the patient. Okay, and then the second round has to be done. When the midwives are transferring these patients to the wards, then they are again making a set of observations. How stable is the patient? Has she evacuated her bladder? And then how much bleeding she has, and does she have any pack, any count, anything inside like that? So all of these things, they should be counted and documented. Because if it is not documented, what does it mean? It never happened. Okay, so make it a habit to write down everything like that. Okay, so that is one of the situations. So when the patient, if the patient comes to you, so there is a standard protocol for dealing with such patients. Like the patient will be angry or something like that. Okay, obviously nobody will be happy that she is something was left inside like that. Okay, so angry patient, don't stop them, let them talk as much as they want, because this is the way, this is going to give them a chance to ventilate themselves like that. Okay, so don't interrupt the patient. Sometimes they can be like very aggressive like that. Okay, if you perceive any danger, any risk, then you can you can go for other things. But first thing would be sit comfortably, don't show arrogance, lean forward, listen to them, but maintain your personal distance. Let her talk as much or him as much as they want. Just say the clues like okay, got it, okay, it happened like this. Okay, repeat after them so that they will know that you are listening and you are registering. If you need to take notes as well. And show empathy, that I'm sorry that this thing has happened to you. If I were you, I would have behaved in a similar way. So that is one of the things. Okay, then composure, like your first reaction would be like, this one is talking badly, so I should also hit him back and talk in a similar way. You are a doctor, compose yourself. Okay, and hide your emotions like that. Okay, and listen to the story and then give appropriate response. Why? Because you have been trained for it like that. Body language, your body language should not be like threatening that person, it should not be intimidating that person. Sit comfortably, never cross your arms in front of you, keep your arms by the side or keep them in your lap, and write down the things if you need to write. Okay, and if you think like the patient is going to be combative, patient is going to assault you or beat you, then you are going to put up some distance between the patient and yourself. You must have seen or heard the stories that the patient has beaten the doctor or doctor has slapped the patient like that. Okay, so if you feel that there is a real threat, then the staff should be getting the cues, because now you will call the security, he is going to hit you or he will close your phone. Okay, so let someone call. This is hidden code. You are not calling in front of him. That call the security to come and take this person like that. Okay, then you have to think about the legal self-protection. Protecting yourself is also very important. So documentation, which is the most effective form of communication, is going to save you here and always like that. Okay, so may take time to write down your notes. So listen to the patients, like I said before, that maybe this patient is under tremendous stress. Maybe the patient has got wrong information. Ask them that what has happened to them. Like mostly if it is a foreign body which was left inside the patient, or patient has suffered some other harm like that. So ask that what has happened. What does this condition mean to him or her? What has it caused? What is the extent of the problem like that? And you will say that this is a bad thing, it should not have happened, but let me go over the notes, let me review, and we will see that where is the problem. Then we can, once we have a clear idea, we have more information, then we can talk about it. Okay, but I will reassure you that we will do our needful right now. We will do the needful right now. We need to take this foreign body out and treat this patient. So that's what we are going to do. So today I plan to remove this body. If it can be taken out without anesthesia, just do that. Okay, without any painkillers, just do it. But if it is embedded, because with passage of time, sometimes even the swabs, they will become adherent to the surface because there is blood, sometimes there is discharge like that. Okay, so you need to see that it can be removed here, or it should be removed inside OR like that. It's up to your clinical justification and assessment like that. Reassure the patient that we will first time, we are going to improve her health, and whatever we find in the notes, we will sit together again and then we will talk about it. We are going to make a committee which will look into the events, that what has happened with a timeline, and then once we have more definite answer, we will get back to you. Is there something else that I can help you about? So mostly these patients, they are scared like that. Okay, that what has happened, they are overthinking. Okay, maybe they have some wrong information from the internet, maybe somebody has given them something which is not like good. So these are the things. Okay, so just talk to them. Okay, and mostly they will not have the information. So once you have given them good information, they are going to be fine like that. Still they want to escalate the level, you will never request that please forgive me like this. No, that's below your dignity. Okay, first do no harm, and then that your second oath, when we are taking oath, the first thing is don't harm anyone, and second oath is heal the sick. Okay, so this is part of your oath, aristocratic Hippocratic oath, like Hippocratic. So we can't go back on that. Okay, and then at the same time you have to protect yourself, and there is protection in the system for you in the form of insurance, in the form of the hospital committees and the response like that. Okay, so that's all you need to do. All W questions: what has happened, when, where, then why. That's what you are going to do. What has it done to you, like that. Okay, and why are you so angry? Because if their anger is out of proportion to the situation, so we have the right to ask them. Okay, then document everything, try to diffuse the situation. If the patient is not listening, or usually the rule is that if I have made a mistake, they will never ask me to counsel this patient. This patient will say that I want to talk to this doctor because he did this bad thing to my wife or someone like that. So as per the system, we will send another member of the same team to talk to this patient like that. Okay, because things can go very ugly, and maybe you remember some incidents where doctors were fired at worldwide. It happens like that. Okay, so you can use different models, but you don't have to stress yourself learning the names of the model, because there is a protocol for almost everything if you will go to the ICDs like that. So just do the needful, because that will be part of the station, and you are supposed to give information to the patient during the procedure. Any question, comments, anything, any addition?
That is all. Thank you.
Okay, welcome. So this one for Dr. Rukaiya. So when you are ready, you can start answering the question. Are you there, Dr. Pia? Hello. Okay. So please do this station. Okay, can you start answering, please? What happened, Dr. Pia? Hello. Okay. Maybe you are mute because, not hearing you at all. Maybe you are mute. Unmute yourself.
يا دكتورة، I think دكتورة رقية has issue with her mic, but she came back now. Straight, we see.
Okay. You can hear her, or you people are also not hearing like me?
I can't hear her actually. I
Yeah,
think she
I'm
has
also
to
not hearing her. So anyone else would like to do that? Sorry, Dr. Kaya, just adjust your mic. That
خلاص أود دكتورة حاضر.
okay.
Okay.
Thank you so much. Please go ahead.
طيب. So she is this case of possible sepsis. 10 days ago, I met early ill and clinical foundation. The patient was very difficult in initial days and was convinced that she will die. طيب, have you been present? Have you investigated your consultant about the question? File is concluded with instruction system. طيب, how do you analyze to identify the risk? First of all, I will identify the risk. What's happening for her? What she's why first? What's the indication for her section? Was it indicated or indicated? After that, was it due to, for example, advanced stage of delivery or due to collapse? Then after that, was it diabetic hypertension? Was she diabetic hypertension? She's obese. She have any risk for infection post delivery, post delivery? Was this risk? She's meconium. Was it immunocompromised as she's diabetic or hypertension? Was it obese lady? or not. And after that I will check was she following, was she given pre-anesthesia كنت شو اسمه pre-anesthesia antibiotics or not given. If not given, if not given, was she given after or not given? Following that, what there's an attempt to give what she have while while she's in the hospital. Does she have any risk of HIV and sepsis, such as she have endometritis, history of abdominal pain, history of fever, history of foul vaginal smell, or tenderness, and she wasn't given any admission and any wasn't taken any culture was taken that mentions she has GBS or wasn't given an infection antibiotic. This is for type and her follow up. I don't understand. History of power vagina. What she was advised to what we advised to sorry, was she given OBD? What we advised about risk of, was she advised about risk of infection, or given to come to hospital if she has risk of infection, or was given a leaflet for that if she has any fever, any abdominal pain, any vaginal smell to come to the hospital. After that, was she given DVT? DVT was she given DVT prophylaxis post delivery after she was sent home? And this is it for us from the risk of.
Okay,
how do you analyze that? Yes, hello. Hello.
Yeah, I'm hearing you. Yeah.
Okay. This is my first question. But how do you analyze the unparalleled evaluation? I will do first, like I said, at this high risk. I would see first her root analysis. Was she was taken full from her admission for the discharge and even pre-admission. Was she pre-admission was she was analyzed for a high risk of infection, such as GBS urine infection analysis was done for the patient taken in every trimester. Was the history taken immediately by the resident and to identify the risk of infection, such as diabetic, or was patient investigated before due to diabetic or not? Was she advised to not to increase her weight and while she's pregnant, or while she's getting pregnant, while she's pre to delivery? And طيب I will do simple root analysis from admission, from her. I will analyze her history, her investigations. What's the cause of her section, was indicated or not indicated, as a root analysis. After that, we'll do for her. We'll do after analyzing the root analysis. We'll write. We'll check the cause exactly. What's it contributed to her risk? Is it avoidable and unavoidable? If it's unavoidable, such as she is diabetic or not, diabetic, could be prevented in next pregnancy or not? And such as if she has BPROM for more than 24 hours without giving antibiotic, and this stuff. And after that, we'll do a report, and we'll do a reporting, and this is analyze the risk, and do for report. We'll do a report for the first one, and we'll send the report to management, to the management, and to do auditing, and do the auditing from now on and 6 months to see if it's did our strategy that we already implemented made these things reduce to happen or not, reduce risk of sepsis and infection in our hospital, and this is it.
Yes, well done. So you're going to get this type of questions, okay? Just give them the factual information, and you are going to be fine. And at the same time, not only you have to talk to this person, his anger is just one of the things. We have to fix the things in our hospital as well, like that, okay? So that is one of the things, that what was the cause, what happened, and do look for the risk factor in the patient also like that. Was she at risk? What was the indication for the surgery? And in the emergency sections, like we need to know that the risk of infection in all surgeries is going to be 5%, but whenever you will do some emergency procedure, that risk would increase to 10% like that. Okay. So 10% is a big number. Then you need to look at the patient. Is she obese, diabetic? Okay. What is the immunological state of the patient? Okay. Is she prone to get more infections? Did she have any other infection at the time of surgery like that? Okay. Where who did the surgery and have the written that all steps were done, how much time it has taken, did she receive any blood transfusion, was it a prolonged surgery? Okay, so that is one thing. For how long she was in labor, maybe she was admitted, she had been in labor for longer period of time like that, and multiple examinations were done, so maybe that is the cause. Then the second thing is in the post-op period, did she receive the prophylactic antibiotics? Okay, and was if the duration of surgery is more than 2 hours, you need to repeat the dose of the antibiotic again and give them the second dose. Okay, and then in the post-op period for these patients who were like in already in labor, you need to give them cover for everything because we are protecting them from the gram positive, negative, and anaerobes. Okay, so give them broad spectrum antibiotic like ceftriaxone you can give gentamicin, and you need to give them flagyl. Okay, need to give them VTE prophylaxis. So all of these things here. So then do the needful, and the patient is fine and proving. And then how was the period after the surgery? Was there any induration on the wound? And when was the gauze removed? You have to remove after 24 hours like that. Okay, if the and then you don't have to apply anything on it, just the clean this normal saline, and she's going to be fine. So was she given instructions on the wound care? Okay, and the wound has healed or not like that? Does she have any offensive discharge like that? So you know that did she have any risk factor for GBS, because GBS is the most common cause for having group A beta hemolytic streptococci, most common in cases of sepsis like that. So even when this patient comes to you, the husband is talking to you, you will say that I would like to see that how is she responding to therapy, because she is in the critical care for 5 days. If there is full-fledged septic shock, you know the chance of death is going to be 60%. So sepsis is not something very small like that. Okay, so you need to dig in more. What happened where at each stage? Okay, you would like to review the notes, and is the patient responding therapy and how she's responding to the therapy like that. Okay, so end on the positive notes that this is critical time for the patient. We are trying our best, and in these like the internal investigation we are going to start. Remember, internal evaluation and the external evaluation. Internal, you are going to do your own assessment. Was everything in place? Things have been done in the concerted way, the way they should have been done. If some step was violated, who is responsible for that? And we need to notify them, and we need to take response from them like that. Okay, many a times you will come across the doctors who will not respond like that. Okay, so you can always complain them, and this can be a reason for terminating their contracts as well like that. Okay, so get the responses from the care team, what happened, and we are getting information from the multiple sources, making the RCA, evaluating, and then give them a definite time that we need 4 times to complete our inquiry. Then we will sit again with you and we will talk to you like that. By that time, the patient would have improved. This person, his anger would have been diffused, but more importantly, having this sepsis. Why it has occurred? Very important for us to know. Sometimes they will get the germs or bugs only from the bed, hospital bed. Imagine from the OR bed like that. Okay, so did someone was caring for her was carrying the infection at that time? Or why he was in contact with the patient? It is because of the patient, or it is because of the surrounding like that. Establish with the timeline. You know the timeline is very important when it started like that. Okay, so among the postpartum complications, the most important thing would be what has happened and when it started like that. Okay. Then you can pinpoint that where is the culprit like that. Thank you. So next one. Dr. Kaya, are things fine now? Or still we are
Yes,
having problem? Okay. I'm sorry.
I
Okay. Thank
finished that station already.
you. Okay. Good for you that you will get 2 stations. Honestly, we didn't hear a word, really. That is one thing.
Okay. You work in the busy unit. Today there was 10 cases and between has been okay.
Okay, dear. So, what is your opinion on this case? What actually has occurred here? What
The
has
same
happened?
consultant, he has two cases. He did the hysterectomy for the case supposed to be oophorectomy and the oophorectomy done for the one for hysterectomy.
Yes. So, two wrong surgeries. So, this what type of event is this one?
This centennial event.
Sentinel event. Remember, luckily, most of the things they will give you in on the exam, they will be sentinel events. Forget the near miss. Near miss, we were about to miss something, but we didn't. It was identified at the 11th hour, okay, and we did the needful. All the events you will get, they will be sentinel events, or they will be, and then you will have to do the serious incident reporting also, like that. Okay? So, how do you analyze this condition?
For this case, we're supposed to make a serious incident report.
Mhm.
We will see what they did, yeah, before the operation, since the admission of the patient. Uh, um, they take the history before the OR, يعني at the time of the shifting. They are checking the ID of the patient or no. At the time of in the recovery area, at the time of endorsement between the nurse. It's they identify the patient at that time or no. In the OR, the sign in who check the label of the patient and why it's happened. There is something with the team. This case is done as emergency or elective case. Is done in the night or in the morning. What else?
Okay. Yeah, the list,
Okay,
it was
then
on the list. Okay, and like that.
yeah, I try to find also some excuse for them why this happened. يعني.
Yeah.
طب, okay, we will see why it's happened. Then
Mhm.
we supposed to do the root cause analysis. We will see um, like is not blaming anyone, but we're supposed to see why is this happen. Why the consultant he book a lot of the patient in the same day. Is all the case is emergency because all the case like elective case. It's someone elective and this emergency add or what, and also we will see is there is the communication between the nurse is something happening and why the this no one identified the patient because supposed to be third sign and before and the endorsement between the nurse from the ward to the OR. Okay, then we'll try to after we will do the analyze, we will do like a drill to endorse to everyone how to this one is supposed to be not happen because this is a very big mistake. Okay, and we will write incident and we will make like also incident in the all the people including And we will, after that, we supposed to, after finish the procedure, uh, at least for the one they did for her, supposed to be her OR hysterectomy and then oophorectomy, they can also complete and proceed for the hysterectomy. And after that, they supposed to, next day in the round, they supposed to go to the patient. We will break that, that we will tell her about this risk management. We will to be sure the patient and the private she's comfortable, not ill, and we will inform her that what's happened with her. They did for her hysterectomy instead of oophorectomy. I know she will be on shock. I will give her time, and then we'll inform her we already make incident report and she has right to go and complain, and we will inform her where is supposed to be to go to complain. That's what I have.
Yes, then these are the points like that. Okay, but always you remember certain things, that if the surgical mistakes occur, if the medical mistakes occur, we call them medical malpractice. So if the surgical complaint is there, we call it surgical malpractice. And always the complaints would occur when there is a break in the system, fault in the system, shortage of staff, time constraints, and they are not taking time in handing over the patients. That is one thing. Here you see, I wanted to highlight, but I didn't. An anesthetist was managing two theaters simultaneously. So timeouts, they are very important thing. First, there are multiple mistakes. Okay, you should say that pre-op rounds are very important, in which the surgical team or one member of the surgical team will go and inspect all the people who are on the list for the next day, like that. Okay, then the resident who was covering the ward should have given proper handover, proper endorsement to the resident inside OR, the one who is covering the OT. They should have made the handover very safe, patient to patient, and on it should be a written handover, like that. Okay, not verbal. I know that people are doing it verbally, but you have to give it on a paper. There are like special printed papers. So the both teams, the outgoing, this the ward resident and the resident in the OT, they have a checklist. They will do that and they will receive their patient with the team. Then at the nursing level, the nurses who have brought the patient from the ward to the OR, they are also responsible for it, that they should identify the patient with the nurse in the OR, the one who is responsible, and they have to go over a checklist in which starts with the name of the patient, identification, IV line is there, and the catheter is usually inserted when the patient is sleeping. Okay, IV antibiotic has been taken, the patient has no allergies, the blood is ready for this patient, and the lab results are normal, and anesthetist knows that this patient is on the list. If any concern at that time, they should have resolved that. So multiple failures. Okay, and then inside OR, the surgeon, the main surgeon, the consultant, who is heading the OR today, he should know that how many cases he has and who is for the oophorectomy and who is for the TAPSO. Then, before starting the procedure, before putting the patient to sleep, we confirm the name of the patient and we ask her that you are here for the removal of the cyst, for removing your ovary. She will say yes or no. And this is not only verbal, you are looking at the notes at that time. Okay, then you start with the roaming nurse. This is the, like, they're checking everyone in, that the anesthetist knows that what the procedure we are doing, what is the expected duration of the procedure, and will this patient need any extra steps, is this patient having any medical disorders, so it should be notified. And then they ask the nurse. So then they ask the surgeon, who are you, what is your role in the care of the patient, like that. Okay, what procedure you are going to do, is there something risky in the history of the patient, if nothing is there, then what procedure you are going to do, do you expect to do any non-routine surgical procedures, what is the estimated duration of surgery, Do you think that you need to transfuse the blood? So how much time it is going to take? Okay. And what is your plan for the post-op care? She will say that I will write it down later. So you are sure you are doing this procedure? Yes, she has confirmed. So she will check the boxes. Then she will check from the scrub nurse. Who are you? What is your role in the care of this patient? So are you ready to deal with this procedure? Yeah. What procedure we are doing? All the equipment is ready. Okay. And if they need, like you are doing laparoscopy, she will ask you. She will ask the nurse. So if you are ready, if they convert to laparotomy, she would say yes. And who is trained by? Another nurse who is going to be sure that who is going to provide everything, because the roaming nurse, she cannot leave the room till the procedure has been completed, and the scrub nurse also cannot do like that. Okay. So here there are multiple procedures. So even when the surgeon is going to start, he has to take permission from the anesthetist and from the scrub nurse. So sister and doctor so and so, we are going to start this procedure. Are you all ready to do it? They will say yes. So this is a systemic failure. This is not failure of one person. Ultimately, the responsibility of doing the right procedure on the right patient, that is, it lies with the main surgeon. Okay. So he should be 100% sure. If you are not sure, just stop. In many ORs, what they do is that they will write down on the tummy of the patient that this patient is for the right oophorectomy, this patient is for the TAPSO. But sometimes these things do fail like that. Like the person was not, paying attention. And what happened? It has happened recently. Like the woman had one broken bone, uh, this femur in the Western world. They had to put the nail, and they put the nail into the right leg, but I don't know how they did that. Only Allah knows that how they did that, because you see it's a very big blunder like that. So these are the things. Okay. So now you have realized. So first of all, um, the point is that how did they must have seen it when they were doing these samples, because when you are sending the samples to the OR, at that time you have to mention again that who some this sample belongs to, this patient and this and that. So this is some very serious grievous hurts have occurred. Okay, mishaps are there. So once the patient would be awake, and then you are going to do the, like, patient must have heard something. So the next day you will go and you will ask the patient that what has happened, what was the procedure, and then you will say that we are sorry that this thing has happened. We are looking into the reasons, and once we have got the response from the doctors that why it has occurred, we have got response from the staff, then we will get back to you. We will talk about it. We are sorry that it has happened to you. We are really sorry about it, like that. And tell us what does it mean to you, because this 138, we don't know why we have removed this, why we wanted to do oophorectomy like that. Okay. And we have done the hysterectomy. So she, and the second one needed tap. So why she needed that one? She was para 4. Okay. And why we have just removed the ovaries like that? So for the one you have removed the ovaries, she is still like, she is also at risk of second surgery, anesthesia exposure, another major surgery, another episode of stress. Okay. And the one who has lost the ovary, she will have the surgical menopause. So these are very serious things. So debriefing of the patient by an expert counselor is very important. This counseling should not be done by the surgeon himself, it should be done by another consultant or another experienced counselor. Okay. And then we will, so that's how you're going to proceed. Notify the doctor that why that he has made these mistakes and what is his perspective. He is also given a chance to express his story. They will write something. Okay. And then we will give the statements to the quality control department. There they are going to see the risk management team. The risk manager will get all of these things, and they will do the root cause analysis, and then they will tell the patient about the results of the investigations. Okay. So the steps we can suggest, like you said, like checks at all the levels, implement the checks and skill drills and reviewing their activities like that. Okay. Usually first time they do something, penalties are not there, but we try to improve the performance of the team like that. Okay. So that everyone should be more vigilant like that. So questioning multi-layered system for the checks, it should be in place like that. Okay. To prevent such errors in the future. Thank you. Fatma. Others should also read the question, okay? Because your exam is just around the corner, okay? 29th today. So everyone should think, what will I say in my answer, like that, okay? And then see that all of these things your colleague has mentioned or not, okay? Then you can take note that this thing should have been there.
Okay.
Like, yes, dear. Yeah, please. So what can you
Um,
tell me about this,
okay.
about this case?
Okay. I will tell her that we are so sorry about whatever happened. First of all, I will confirm her name, and she is the patient that this issue happened with her. Then I will show her my apology about whatever happened intra-op, and I will tell her that uh, actually uh, this complication could happen in your situation, and when you sign the consent, uh, at the consent there is written the indication of this surgery and the risks that it could happen, like uterine perforation, bowel injury, blood transfusion, anesthesia complication, and I assume that you signed on this consent before before operation undertaking to you, and unfortunately, this complication happened to you, and alhamdulillah, everything was fixed. Um, um, and I will assure that um, the primary team and the primary team that was involved in this case come to her later and talk to her, and they should show her their apology about whatever happened, and to acknowledge the mistake that it happened or the complication that happened, And if she wants to complain, tell her this is your right to complain, and give her the information how to complain, and try your best not to accuse or name any one of your member team, or throw the mistake on any one of the member team. You have to be professional. um, and you have to tell her that an incident report have done, and ethical committee know about this, and will assure you about the report that we will do, and we will update you, and inshallah, whatever had occurred will never inshallah reoccur again to you. And I will tell her that this person, this like uh, 3 from 1,000 patients who underwent this operation could have this complication, and that's it.
Yeah. So these things do happen like that, okay?
Yeah,
And just
and I will be sure that I do like a risk management also. I will go through risk management, how to do it also.
yes, you would like to do that one. And
Yeah, like I will assure you that incident report has happened, and we just did like risk management team, consists of the consultant, senior registrar, and senior residents. We will do the root cause analysis. We will check the patient factor, the hospital factor, and the surgical team factor, and we will do like a risk management report. We will be sure that whatever had occurred will never reoccur again. We'll update you about the report. We will do the next time the drill, the audit, and we will inform the national, we will inform locally the hospital and the national, the Ministry of Health, and we will update you about the results like this.
yeah, that is one thing. So whenever you are disclosing the adverse event, the environment, just like we are talking, uh, it should be safe, okay? And at least two members of the team, they should be together. One person is never allowed to go and talk to the patient like that, okay? That is one thing.
Okay. Mm.
So then they should ask the patient how she is doing, okay? How is her health now, like that, okay? And then you will go and you will say that we need to tell you about something which has happened. It was totally unexpected, but unfortunately it has happened. And then you will go on, give her good account of the detail of the problem that has occurred. Okay, and if she shows any reaction, you'll say that I will give her time to show the reaction, and then I will ask her that what is the way forward. Okay, this has happened, and after that we have done this, and this, and we expect that the outcome will be one, two, three, four, like that. Okay, and we expect that you're going to be fine by that time, and then tell her that what is the effect on her future health, like that. Okay, and what will be the impact of the adverse event on the patient's family as well, like that. Okay, and we are doing everything in our reach to do the things, and most likely this is the expected outcome. Okay, that is one thing. That's all you need to tell her. What is your response? Register her response, her questions. Okay, she needs time. She has any other questions, she is worried about something, then we are going to talk about that as well, like that. Okay, usually the patient will not be angry, then they understand, because we have, that's why we are consenting them that these things do happen. Very important that the consent should be taken in after detailed explanation of the things, so that if anything goes wrong during the procedure, the patient has some understanding that why it has happened, and then they can understand it, and then they are not going to raise the alarm. The problem is that surgeries are not easy. Always things will happen. Even the smallest surgery, you have to remove the cyst, sometimes it may go wrong. okay, like that. So, and the patient can have the material losses. So we have to tell them about all things which will cause some material loss, some serious significant loss. That's why we are consenting them, okay? And things do happen, then you can always say like this: remember that before doing that procedure we told you that we have risk of having this complication, so unfortunately it has occurred like that, okay? Diffuse the situation like that. And it's all the surgeries they carry risk, okay? All the surgeons, they are safe surgeons, that's why they're taking up the surgeries, but sometimes somewhere something may go wrong, so you have to be ready for that. And the way to maintain your skill is practice updating yourself. Doctors are lifelong learners like that, okay? And try to focus on the things you are doing like that, okay? You are in the OR, just mind your own business like that, okay? Don't have to go anywhere like that. So, and documentation, proper documentation is very, very important like that, okay? And usually in such patients, like things have happened, so we have called everyone concerned. We are debriefing the patient. We are maintaining the elements of clinical governance. These three things I told you: debriefing, clinical governance, risk management. They all come together, and in this case these things do happen, but this is not like a routine outcome, so that's why we need to write down the serious incident reporting also, report as well. Thank you very much. Let's go back.
دكتورة
Yeah.
طب in this case I can first answer I suppose not the one I inform the patient. I just will go to reassure the patient, inform her consultant in the OR within 2 hours he will come, he will inform her about everything.
Yeah, the point is that this patient, like who has gone undergone this surgery, something like that, so she will also be, most likely she'll be sleeping at that time, okay? And remember, debriefing is always done by the most senior member of the team, that is usually your consultant, okay? Consultant and specialist, or consultant or senior resident, they can go. And if the consultant is facing difficulty, he can go with another consultant like that. But usually the patient, the practice is different from the bookish things. By the
Yeah,
time
but
you
I
would
mean,
approve,
it's right to tell them the examiner first. I will go to inform the patient, and I will, if she will, it's okay for her. Her consultant just within 2 hours he will finish the OR, and he will debrief her.
yeah, it is okay. That is one thing that she has gone. She is busy like that, and but you will ask the patient that please wait because the your doctor is busy inside OR, and we need, in the meanwhile I'm going to go over your notes to see that what exactly has happened. Then we'll be talking to you together.
Okay, we can tell like this in the exam, and when then
Yes,
we'll inform
yes,
he,
you
the
can say.
consultant, he will inform like this. We'll talk with the
Yeah,
patient like this. Ah, okay.
yes, you can say that that and for me also, like they are telling you that go and explain to her. You will tell the patient that I need to see your
I'm not
notes.
in the OR. I will see first. No.
Yeah, I will see first. Always review the notes. Never tell the patient, yes, this has happened because see, why do we use the spikes model? You can implement that on multiple sites. See that what information the patient is carrying with herself. Okay. And what do you know about it? But has someone talked to you after the procedure, after the thing like that? So what did they tell you? So what do you personally think what has happened like that? Okay. So you are also going to ask the questions like that. Okay. And then you will say that I need to see the details. I was not scrubbed during your operation like that, so I need more details about it before I can talk about it, okay? In the meanwhile, we need to focus on your health, that you are doing fine and the things are okay like that, okay? Please wait for you are stable at the moment, so let me go over your notes and then we can talk, and in by that time your consultant would also be free, and then we can have a detailed discussion around your thing like that, around your
طيب,
your
another
package.
question, doctor, about the consent. If the,
Mhm.
because sometimes we tell the patient you are signed for this consent. If
Mhm.
something is not written about the complication, we will continue the same, and for at that time, just she has right to complain, صح?
You will ask her, did they tell you something before the operation that that undergoing this procedure can increase, can be like serious? You can have this problem. What you informed about it? She will say yes. Actually, verbal consent is valid only at the during the emergency situations like that. Okay, that is one thing. So, did anyone talk to you about this? Did they tell you that there is risk of this problem? Were you given any leaflet? Were you given any information leaflet? Did you read that? Were you familiar that this thing could have happened? That is something like that, okay? But here you can see that there are certain missteps. The serious patients, yeah, we have to debrief them. And counseling is very important, before the procedure and after the procedure. In my whole life, I have seen two cases of missed miscarriage. I share my experience. I don't want to waste your time, but I want to tell you that don't take any operation as a minor or major. An operation is an operation. Full stop. One very experienced, skilled, very very nicely trained person. He was trained in France in laparoscopy and everything. He was doing certain procedures, okay? So both cases of missed miscarriage, and never undermine this missed miscarriage or the molar, because the products of conception, they just stick like you have put some other bond, some alpha, some glue between the baby and the uterus, like that, okay? So give them time, reassure them, never be in a hurry. Try to use this misoprostol something so that the contents, they would loosen up. This guy, he started doing the ERPC in both cases. In both cases, the products, they were adherent to the uterus. And you know what happened when he used a little force? Because at the end of the day, uterus is also a muscle. Okay, so both times the lateral wall on the left side, it was injured. Okay, and it led to the perforation of the laceration of the uterine artery. Both times the patient poured blood as if you have turned out the tap water, like that. We did laparotomies and we ended up doing hysterectomies. We couldn't control anything like that. So things do happen. Do under ultrasound guidance. You are not sure, don't think that what the other people will say. Why do they keep ultrasound machines on the OR? Because they want you to use them and keep your patient safe. Okay, so don't omit anything. And there is nothing personal, nothing like losing your face. Let the people say. Even if your success rate is like 100%, still the people would say something about you. Don't mind that, okay? Just be a safe doctor, whatever you do. If you are going to the DR, you are going to the clinic, look at the start from with the GPE. It will take 1 extra minute. Do the abdominal examination, then go for the VE. I have seen the people, they will just go and do the VE and khalas. No, do full examination. With passage of time, you will become very quick also, okay? And the juniors, yeah, juniors are very helpful, but you are the senior. You have two eyes, you have a brilliant brain, use them. Well done. Let's go to the next one. So, Dr. Muhannad.
طيب أوكي. إيش بهذه؟ طيب short case radical framework risk management fishbone analysis duty.
Just think about them, because your next case, it will be focusing on these things, okay? So how you can make that things safer for your patient, like that, okay?
I don't know what is fishbone analysis or duty of
Don't worry, we'll talk about it in a bit. Don't worry.
okay.
This is
Timeouts and inspection, risk factor identification, patient development, double check, trainer, serious event. طيب okay.
what is this radical framework. Okay, I'm going to show you, but I wanted all of you to go over this thing, that what is this. These words you are going to use when they give you any patient where some problem has occurred. You will say, I will use radical framework for the risk management. For finding the root cause, we are going to do the fishbone analysis. Okay, the patient, I will inform her about what has happened. I will do it honestly. This is called duty of candor. It means that something has gone wrong. There is some adverse event, but the patient has right to know. So you are going to give her the truth, like that. Okay, you are going to give her the truth. This is the duty, that you are going to be honest with the patient and you are going to give her the facts that this has happened. So this is called duty of candor. Another thing, it should have been here. I don't know why it is not here. That is called probity. Okay, what is probity? These are the less commonly known principles. Be honest to the patient. Probity is equal to honesty. Okay, honesty everywhere. Why we are doing this procedure? What you are going to get from here? Is this procedure really helpful? You are going to be honest with your patient. Okay. Then in the questions, you will say, when they will ask you that how you can prevent the complications, you will say there are several ways of preventing such damages such situations. A working multi-layered system should be, a multi-layer check system should be in place. We should do the skill drills. We should follow WHO safety checklist. What is the WHO safety checklist? Right person, right procedure, by the right person, at the right place, at the right time to get the right results. Okay, right site surgery, right place, everything should be right like that. Okay, human error. Human error is one of the non-technical things. Okay, this is not technical thing. Maybe the patient person providing the care is overburdened, like they have too much work. One resident should not be responsible for more than two patients. But on ground, it doesn't go like this. Okay, you people are dealing with the whole floor, and one resident is there, so things would happen. So, adequate staffing, a safe handover, discussion among the team members, good, clear communication. It is going to prevent the human errors. They should not be fatigued. If they are burnt out, they should be given paid time off. That is important to maintain the quality of the work. Staff fatigue. Again, overburnt, overworking, they are exhausted. Okay, so they should get the backup support. If they need to talk to someone, yes, they should go. If you need to bring the locum people, yes, you should bring them in. Okay, doctor to patient ratio should be, a doctor to patient ratio is predefined, and it should be maintained like that. Okay, and technical support, and it should be provided to everyone like that. Okay, then the timeouts during surgery, where we are checking that everything is fine, everyone knows that what we are going to do, the blood is ready, what is the hemoglobin level of this patient, what is the thyroid status of this patient, what are we doing, and has she consented for the procedure, and if she has not consented for the procedure, she will not do. I have seen the consultants doing the BTL, but the consent for the BTL should be in place by 36 week of pregnancy. Then you need to see that are there any discrepancies in the record of the patient or the lists. See that what is written in the why what we booked the patient for, is that written very clearly and the patient has consented for it, and what is written in the OR list. The day before your surgery is very very important. You need to do the pre-op rounds. You need, and before starting the pre-op rounds, you have to look at the lists, who is on my list, and did we really plan this procedure on this patient. So that's why you need to take time to review your patients like that. Okay, any patient you come across, you will look at the risk factors. Does she have any risk factors for the surgery? So this is like the risk register. Write down that this patient has this and this issue. Then involve your patient in their care. What is their perspective? If the patient is hoping to have a positive outcome, really they do wonderful, and they are going to have smooth surgery and they are going to improve themselves. So involvement is very important. And if the patient sounds a little bit reluctant that she doesn't want to have the procedure, or should I go for it or not, don't reschedule, cancel the things. Patient will go back into the loop, go through the system, and again follow the same steps. Otherwise, the things will be moving back and forth and something would go wrong. And double checks, training, environment, CS incident reporting. There are certain indications everyone should know about that. Okay. And patient should be discharged in a good condition, and this should be written in the discharge summary. Now everything is kept in the electronic health records. Don't forget to tell your juniors, because they are the one, R1 are usually discharging the patients, that add one line in the end, patient discharged in a good condition. Okay. Then the instructions you are giving to the patient at the time of discharge, they are very important. Here, what you have to write, what medicines she should be taking, how often she should be taking, with meals, without meals, and do they need a fill up, refill, or they will take only for the duration of the therapy mentioned on the page like that. Okay. Do they need to restart any medicines, like they were having some medical disorder something, do they need to restart that? So the post-op medication directions, everything should be very clear. Then go to the then talk about the procedure if you have done. Even for the episiotomy, you need to tell her keep the area clean and dry. Don't touch the don't touch the genital area without washing your hands first, and wash your hands before and after changing your sanitary pads. Don't have to apply over the counter creams to the area. If this is a cesarean section, tell her don't lift heavy weights. Clean your wound with the normal saline or just the plain running water like that. Okay, complete her if she's taking antibiotics, complete that. So complete that. If she's taking BTE prophylaxis, tell her that for how many days she has to take it and when she has to stop. And always tell them that observe your urine, and if the color changes or the smell is bad, just go to your general practitioner because they will do the urinalysis at the time and they will tell her. Always tell the patient that how they should maintain their health, like they should get up and take rest at the appropriate times. They should not make it a habit not to sleep during the day. They can take a nap at the bedtime in the afternoon for 20-30 minutes, but not more than that. Healthy eating habits, when they can start taking the normal food, of course. Even in the cesarean section, we are not operating on her gut, so she can start taking the foods once she is out of anesthesia. Healthy diet, healthy habits, no smoking. Tell them when they can start having, and no bathing into the swimming pools. No swimming pools, they can take showers, whatever they want. And then tell them you have to go to such details. Everything is actually written, you just have to give that paper to the concerned patient. When they can start driving, when they can return to work, when they can start having sex, when they have to initiate the contraception, what about the breast feeding in our discipline, and when they should seek medical attention. Everything should be written. There should be number of the hospital if the emergency arises, and there should be the sport group link should be there, and the hospital website link should be there where they can go and find the information. Okay, so all of these things should be there on the discharge summary. That is a very important document that can be taken to the court as well. You will always gain marks. Check, 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 multi-layered system. This slide, I want all of you to learn this slide by heart like that, okay? Because something from somewhere, it will come to your mind like that.
Where is
Okay.
the slide, doctor? I
You
don't see
know,
anything.
you on your page, it should be there on your page, on your website,
Uh-huh.
because all of these lectures are on your the PDFs are on your this one on your web page. Okay, if you don't see it, please tell me. I will, okay, I will check it again that that you are getting everything for it like that, because these are just like the key words to draw attention like that. Okay, that is one thing, that you know the metrics, you know the things. And regarding these frameworks and everything, that the things are here, so many documents, all of them are there, but I wanted to discuss with you guys like this is the forest spot, because tomorrow inshallah we are going to do the appraisal of medical literature. So the charts, the graphs, the studies, everything we need to cover here. Okay, because they are likely, they will be there on the exam, like two questions you are going to get only from this 3 days activity like that. Okay? That is one thing. Okay, dears. So this one for the
Doctor, sorry,
no, no, no. Please
again,
go on.
what's this mean for fishbone analysis?
Yeah, I will tell you something. When you are doing something, um, how many things should be in place? Whenever we are doing anything, you just name it. It is in our notes as well, but I don't thought that it is easier to come this way. Like whenever you are doing something, okay, your patient has come to you, and you are just looking at the patient like that. Okay, so this patient, you are admitting from where? You are admitting this patient from the OR like that. Okay, if you're admitting this patient from the ER, or you are admitting this patient from the from somewhere, from the clinic, or this patient would have been referred to you from somewhere else like that. Okay, that is one thing. So when we do the fishbone analysis, this is the fishbone analysis, we are trying to establish facts. Okay, so here we are going to start everything. You can identify that this is the home of the patient, like the patient has come from the time the patient has entered your hospital. What you will do, you will write down that what time the patient came here and who was the first person to see her and what was the outcome like that. Okay, so in our medicine, when we are talking about such things, we are telling them who reviewed her, what was the condition, and then who received her inside the OR. This is just a template. I'm telling you that what exactly is the fishbone analysis. This is the template to explain. This is the timeline. Okay, something goes wrong. One person stands next to the whiteboard in the quality control room or the risk management committee room. Then they will start writing, okay, this is the patient, the name, everything is here. This patient came here, who saw her at this time, what was the condition, things were fine, okay. Who received this patient, what they did for her, things were okay, everything was fine. So you will write down here. Then what happened, what was the course, what were the progress notes, everything you are going to write here like that. Then with the time, what happened, what situation evolved. So the patients, the consultant, the senior, junior, everyone was ready to care for her. Okay. So the fault is not at the human level. Okay. Were the machines, things working well? So nothing was wrong in the system as well. Nothing was wrong with the machines as well. Okay. So then the drugs, this patient got the right drugs at the right time. We are talking about the interventions. Everything was given to this patient at the right time, or was there any delay in providing care? Was there anything abnormal? Was it noticed? Was the consultant notified? Was the patient informed about her condition? And did we write the daily reports? Everything was okay. Everything was fine for this patient. Okay, what we did next for this patient? We did surgery for her. Who did the surgery? What was the indication for the surgery? Was this WHO safety checklist was implemented or not like that? Okay, so these are the things. Basically, in the fish mode, you are going to answer all the YWH questions. What happened? Where? When? Why? Who was there? Because basically, you are trying to find out the basic cause. That it was the human error, it was at the level of the human beings, it was because of the environment, like the environment was not safe for the person, or the assessment, the measurement, it was not good. Were we able to actually assess the condition of the patient, or we didn't? Was there, were the machines working, or the fault was at the level of the machine, like machine was not showing you the right CTG, so the problem happened. Then what about the materials? They were available, strips were there, things were there, everything was there or not. Then the human beings, the men, those who were managing the patient, they were adequately trained. Were they informed? Were they aware of the condition of the patient or not? Then what method we used for the assessment of the patient? Okay, was that appropriate? The treatment we provided, the drugs we provided, the care we provided, everything with our method of providing the care was fine, or it was not? Still there was, what was the defect? After evaluating all of these things, we are able to pinpoint the defect. So then we can say that the problem was in the environment, it was in the measurement or the assessment of the patient, equipment was faulty, material was not faulty, or it was not available, or then the man, the persons who came across this patient, they neglected something, or our method of caring, the management we have done, it was wrong like that. Okay, so then we can pinpoint that what exactly was the defect and how we can fix that, and then according to the light of the assessment like that. Okay, so anyone will repeat after me that what were the things? Environment of the patient is very important. Environment, then measurement, what exactly happened, how we assess the condition like that. Okay, then machines, like what machines in the OR, in the ER, the cuffs for measuring the blood pressure, they were accurate. Were our thermometers were accurate? Did they reflect the actual results? Did we use the appropriate size cuff to assess the BP of this patient? Was the sonic aid working well? We, we were familiar that the patient's baby has abnormal heart rate, something like that. Okay, material, then man, and in the end, the method. So this was an human error, or it was like the method was wrong, and then the defect. What exactly is the defect? Where was the defect in all of these things? So this is where we are plotting all of these things. We are plotting it on a timeline. Okay, is it clear now?
Yeah, thank you so much, Doctora.
No problem at all. These simple things. So actually, there is a lot of material like that. Right from the quality control, that how you are going to do the timelines, what are the effectiveness, what is your efficiency, what is your proficiency, all of these things. They can ask you like that. So that is one of the things like that. Okay, and then there are many other things like this topic of clinical governance is very important. What exactly does it mean? And how do we use that in our actual practice like that? Tomorrow inshallah we'll be doing that. Sometimes these are very important for you. What is a systematic review? What is like the this meta analysis? You should be knowing about that. Okay, then what are the different parts of the non-technical skills? All of these are non-technical skills like that. Okay, what technical skills you should be having to answer the questions like that? So a lot of discussion is here. So we will start and we will do that one like that. Okay, so how do we focus on the errors, how we can eliminate them? Actually most of it is just simple common sense like that. Okay, know a little bit, but implement that in the right way. Okay, that is one thing. Okay, so can we do one question before we finish? Yeah, Dr.
طيب
Muhammad.
okay. Yes, I'm here. So
Okay.
his patient is 4 days after spontaneous antibody because she's feeling unwell. Okay, so blood pulse is 120, blood pressure is standing over temperature 39. During examination, cause for was removed from the posterior vaginal fornix. The patient and the family was very upset about the situation. We would like to file a complaint. First I will ask the patient. I will introduce myself, Dr. Muhammad. What's your name? Which name? I will see if the patient is standing or sitting. I will in this in a small tone. I will try to talk to him, or them, or the family. I will ask them first how is her delivery, what's happened. After that, after what is delivery, what's happened there. Was it complicated? Was not complicated? And was it normal delivery or not? Was it she was bleeding in delivery or not? Then after that, I will ask her about when I will ask for, I will identify the risk first. I will tell that I'm sorry what's happened. I will try first to look, I'm sorry what's happened. Usually it should not be happening. We are looking first for the causes. I will try to identify the risk for this. I feel them. I feel that what happened. This should not be happening to anyone. Especially if patient, even if patient is postpartum, it shouldn't be happening. I will ask the family why it's happening. First, I will ask them any risk factor from. I will take the history from the any risk factor. Anything was like, for example, was bleeding, and was there was the bleeding, was difficult delivery, was episiotomy, suture wear in OR or theater, and post was she examined with suturing or not? Was she done examination under? Was she examined after they finished the exam? After they finished the suturing, they examined or not, vaginally or rectally. After that, I will check her any previous history before. any history of diabetic hypertension, any cause to have increased risk of sepsis, and other than that, the cause was by itself. Then after that, I will look for I will look for the quick assessment. I will examine the patient. I will take from my urine. I will take from my urine analysis. Or say for a swab in general. Examine general vital signs and weight. I will look for sign of thyroid, sign of sepsis like cachectic, pallor, and I will sorry. Yes, I will first I will give her after that I will vaginal examination or abdomen soft lax be tenderness or not, chest, any sound, any chest pain. I will ask if she has any lower limb edema or DVT. I will examine the patient. I will take culture from the patient. I will do ABC, secure airway breathing and airway breathing and circulation. After that, I will take breathing. I will give her bolus. I will give her postpartum antibiotic, and I will take culture, blood for septic culture. I will take blood culture, urine analysis culture, and vaginal swab culture, and endometrial culture. And this is it. After I will give her DVT prophylaxis. After that I will give her bolus 1 to 2 liter, and I will give her after that I will give her paracetamol for reduce her temperature. And I will do after that, I will take from her CBC, thyroid function level, LFT, RFT. نسيت وين كرشة فيها أيوة CBC كرشة السي reactive protein LDH C active protein lactate and lactate. After that, I will. This is my management to start antibiotic for her. I would admit the patient, start antibiotic, put her on HD unit with DBT prophylaxis. After that, I will speak to the patient why this happening, how this happening, or this happened to you first. I'm sorry this happened to you. We'll try to look for why it's happened to you. We'll try to apply something called the what's his name. We'll apply for we'll look for the cause why it's happened. We'll do a radical framework to analyze from her admission to her for her delivery what was happening. Was it with the staff there? Was it the staff? What's happening was that they conducted the count for swab was done probably at was it done by senior junior physician? Was that the nurse was done with the doctor while suturing or not? And was it junior? Was he a junior or a senior? Again, and the nurse midwife was trained one or under training, and was that time shift was they have a shortage in the staff at the time and was the patient while in labor room, was the patient felt any finding from there while in her admission? Did she have fever and vaginal smell when discharged, and no one respected that? Was she complaining about that as well? Was she complaining of was there anyone asked about any complaining about any fever, any redness, any vaginal discharges while in her admission? And open discharge, was she giving a leaflet for a leaflet or instruction to come to the hospital if she has any complaining such as fever, vaginal discharges, and itchiness or dizziness or vomiting, and I think this is it. I will do after that. I will do here risk management. After that, I will do the risk management. I will write the reasons why it's happened. After that, we will write a report, in which that the report will be sent to the management and the department and management of aspiration. They like to apply a strategy to prevent this happen again, and we will try to will re-audit 6 months again. Was our recommendation was implemented or not? And we'll tell the patient if she wants to complain, she has the right to complain fully, and we'll tell her where to complain and how to complain, and and how to complain. And we'll try. I'll tell that one from the patient. We'll emphasize that we'll try to we'll we'll try to prevent this from happening again in the future, inshallah. And this is it from.
So that's all you need to do, okay? So don't be upset if you see any type of things. Sepsis is like, you know, it is one of the like top 5 causes of the maternal death, like that, okay? So look up the things that you need to see. You can say things like this: I will implement sepsis 6 bundle. Okay, that is important. That is one thing, okay? Clinical governance, multidisciplinary team. In each station, say something like that, okay? Which will
Okay.
catch the attention of the examiner, okay? Surviving sepsis 6. So that was from the NIH, ACOG. It was later taken up by the other colleges. So that is the thing, okay? Find the right antibiotic. Risk management. Everyone should know the role. And at the same time, nowadays, you will say in each station that you will ensure that we are maintaining good communication with the patient, like that. The patient is getting all the information, the family is getting all the information, and rest of the things, yes, we are fine. So level 2 care, okay? And this is not level 3, because in the level 3, patient will need cardiorespiratory monitor for the sport, like that, okay? That is the thing. So sepsis, how do we manage that? You should have started this MEOS chart. Okay, I would initiate MEOS chart for the ongoing assessment of the patient and to provide clues to the next step in the management. Because MEOS chart modified early warning scoring system. If something will be there, you are going to pinpoint that you can identify that very easily, and then you can talk about that, like that. Okay, it will be easy for everyone to understand and keep the record of vitals, continuous BP monitored, continuous pulse oximetry, continue and the and the this temperature monitoring every hour. The start with the crystalloids. You have to strike a balance. You have to keep the patient hydrated, and you have to prevent the pulmonary edema as well. So, say 80 ml, 20 ml per kg body weight that is given in the first hour, like that. Don't go into the detail. Just remember, we can start resuscitation with the oxygen. Then if the patient has like compromised function, and the pulse rate is 120, so it means that the patient is already going into tachy. It is more than 110, more than 100. So oxygen will see that what is the respiratory rate. Patient is likely to have tachypnea. What is the SpO2, and do we need to give her anything else, supplementary this oxygen. And the IV fluid start for her, broad spectrum antibiotics within first hour of the diagnosis. Many antibiotic combinations can be used in the postpartum period. Cefuroxime is equally good. Cefuroxime, and you will combine that with you can give with flagyl, like that, okay? If the patient is not sensitive to clindamycin, we will give that. Benefit of giving clindamycin is that it will switch off all exotoxins, like that, okay? Antipyretics, I will use non-SAID, NSAID antipyretics, like give her acetaminophen, okay? We will send bloods, cervical, the blood, urine, cervical fluid, low vaginal swabs, everything for culture and sensitivity to determine the sensitivities for the oral antibiotics. For the antibiotics, set of observations, monitor that, involve the family members, look for the condition of the patient resuscitating or not. Do we need to apply the vasopressors? Multidisciplinary team is there. What is the urine output? Is the patient improving? Not improving? What is happening? What we need to do, like that, okay? So say things like that, and seeing the patient as frequently as hourly, and then 2 hourly, and then we can go to the like 6 hourly, depending upon the response of the patient. Do we need to change the antibiotics? So that is up to the judgment of the HTU specialist or the ICU specialist like that, okay? And everything should be documented in her notes like that. So that's all you're going to do. Once this episode is over, again, debriefing the patient about her condition would be very important like that, okay? And detailed notes, detailed documentation, and the follow-up care. Okay, dear doctors. Any question, any problem?
No, thank you very much, Dr.